My name's Dyfrig Ap Dafydd. I'm a GP in Llangefni and Anglesey, and I've been a cluster lead for Anglesey for some years. I've recently started as one of the primary care leads for the planned care team. One of our main programmes is the Community Health Pathways. This is a suite of guidelines and pathways for a growing list of conditions. We've got hundreds of pathways across Wales. We're gradually spreading them out. These are edited by GPs, they're based on up-to-date evidence, they're updated, they're reviewed, they're discussed with national clinical networks, and then localised in all parts of Wales so that your pathway shows you what services are available to you, how to access them, what's around. I think this is going to be a very useful resource across Wales. Long gone is the whole looking through your drawers or filing cabinets or posters on the wall or posters on the nurse's wall or posters on reception walls, trying to remember who to refer to, only to find that it's an old link or an old phone number that doesn't work anymore. It's a really useful system. The chronic kidney disease module has just been revised, and the national renal team have been very involved in this. Part of the reason for this push is that Flozins have changed the way we're going to manage CKD. Regardless of what it does to your HbA1c and diabetes, Flozins protect you from cardiovascular events and end-stage renal failure, and the numbers are astounding. It's very much like what's the next generation ACE inhibitor. We want our patients with CKD on ACE inhibitors, on Flozins. We want their lipids nice and low, because ultimately it's all about protecting our population from heart attacks and strokes. The guidance is very clear, it's very straightforward. I'd suggest everybody have a good look at theirs. If you need a password, please get in touch with any local teams you have. You can always contact me and I would forward you on to somebody to give you passwords. The QI project has been brought out, and we're going to be looking at various issues in CKD. There's also the QI project in cardiovascular disease, and I've built searches for these that we're going to be sharing with everyone. Now, the headline search is going to be very similar to what you're going to get on the portal and in Audit Plus, and that will give you things like, how many CKD patients you have on the register. That's the only QOF search you have left in your system. So the QOF indicators CKD have been turned off a long time ago, and you won't know how many of your CKD patients have had their UNEs done, their ACRs done, blood pressure done, unless you've created that search yourself. And certainly the prompts you might have had back in the day to encourage things like ACR monitoring and blood pressure targets, they've all disappeared since QOF was inactivated, in much the same way that we only really get to see 3 out of the 8 processes in our searches for our contract in diabetes, which is frustrating when the assurance framework is looking for how many of all 8 we've measured. I've added those into this project, and I've added diabetic prompts and templates into this as well. This search will show you your CKD population, those coded, those who probably should be coded, who've had their blood pressure, is its target, who's had UNEs, ACRs, how many of them are eligible for Flozins, how many are on Flozins, how many are eligible for ACE, how many are on ACE, simvastatin. The reason it's useful to have this search in your system is that you can run this anytime you like, and it'll show you how you're doing. So if we're hoping some of these figures will increase over the year and you'll see a nice trend. You can export these yourself into Excel and do your own graphs, although that will be available through the portal. One of the things you can do in EMIS is also you can run a search on a relative run date anytime you like. So you can, even a few months in, plot a few searches over a few months to see how you're doing, which is very useful when you're looking at QI in-house, trying to review your own PDSA cycles, looking to see are they working or not. We've done similar things for blood pressure, and I'll come back to that in another video. The CKD searches are all under here, and they're broadly split into coding, eligibility, monitoring, and screening. Coding is looking for those on the register, looking to see how they correctly coded G1 to 5, A1 to 3. There's a few where they're probably not correctly coded and they might need review. There's a whole bunch of patients who haven't been coded with CKD who probably should be coded with CKD. And if I choose one or two of these as an example, what you'll see is we've linked the searches into the prompts you would have had back in the day when these were active in QoF. So this person, we're getting some diabetic prompts. So this is recognizing this is an EMIS prompt saying he's not had a foot check. If I hover over this one, assurance concern, it tells me what missing process is. So I know that this person is missing a foot check and smoking. You can't see that because it's hovering outside of the screen. I can't expand the screen because it shows patient identifiable information. The next box is one where there's a CKD high-risk concern. So this is looking for things like a 4-variable kidney failure risk score greater than 5%, and that will work it out in the background for you. That's something that we can't necessarily share. It's just going to prompt you to go offline and check that yourselves. That's to do with MHR rules on devices. This will look in the background to see if this person's eGFR has dropped greater than 15 to under 60 in the past year, or if it's dropped more than 25% in the past year. And that's what it's showing there for this person. You can't see it, it's hovering at the screen. It's telling me we need blood pressure, which was 139/80 in March 2005. It knows the target for this person is 130/80 because they've got raised ACRs. It's suggesting that the lipids are not to target because there hasn't been a non-HDL drop of greater than 40%. And then these are other prompts that are part of something that we do elsewhere. And then this one is the example here, is the CKD staging code may need review. Now, if you double click on any of my prompts, it will open the cardio-renal-metabolic template. And this template will go through the issues from both of these QIs. So this person's cholesterol is greater than 4. It's suggesting that the CKD coding likely needs review. They've been coded as CKD stage 3, so they haven't got a G15A13. It's proposing G4A3, EGFR is 25, which means that G4 is appropriate. ACR is 212, which means A3 is appropriate. So if I'm happy that that seems a reasonable coding, I will code. It's again pointing out that the lipids need more aggressive management. This patient is a very high risk CKD because they've got greater than 15 drop, greater than 25%, and their Q risk, their 4-variable kidney failure risk score is greater than 5. Any blue thing you click and it'll take you off to the website for that. If I go back to the patient, if it's got a template which is broadly based on the health pathways guidance. So again, it's really about prioritizing reduction in cardiovascular disease events, death, and dialysis. We want to prevent deterioration. We've got to emphasize lifestyle. I think medically, the focus on reducing ACR, tight blood pressure, ACE, flozins and statins. Links to the pathways, so you can look at that if you want some more information. I've put the Wales passwords in there for now. Make sure we're ticking annual reviews, not good at that. Links to the kidney failure risk equation score, the latest EGFR, latest ACR, advice for patients, but also links for the patients on everything you need to know about your diabetes and things like that. So it's useful to have these in one place. I've put in some of the diabetic stuff as well, and I'll show it while I've got this patient up. If they're on insulin, we really want to make sure they are getting advice about driving, and again, links to trend that we can either text through Accurix or print off for patients, or if you're being very fancy, automatically print them out as soon as patients are sent in so that they can just be handed to the patient and that's the job done. But it's nice to sort of tick and make sure we are giving this advice. Diabetic review template, and again it's about focusing on the 8-9 processes there. There's links to NICE on what we should be managing here, and just for reference in diabetes course, this guidance that's suggesting Q risk 10% or more, we really should be considering flozins earlier. I sense from some of the stuff we're reading that we will be increasingly pushed to consider flozins earlier in diabetes simply because the massive reduction in cardiovascular events. Links to type 1 diabetes, links to my Desmond Wales, links to the enhanced service. This is the old National Enhanced Service, which most of us will be claiming for, and I think that's where it reassures me slightly that most of this QI is going to be overlapping with diabetes. And then the template will show you any missing processes. So as I said before, this person's missing their foot check, they're missing their eye screening, and we need their smoking status because it's been a year. As part of the QI from last year and continuing efforts around making sure that we focus on lifestyle, I've left in the links to alcohol if they've not been recorded, alcohol advice, Dan 24/7, which is part of the Kaiser-Veriad hosted alcohol sports service across Wales, the old QI project if you want to look at that, and then it's got processes that are up to date as well. So I know that this person's had their UNEs up to date, had their lipids up to date, had their HbA1c, and they've had their weight done. So if I go back to the searches here, what we'll find is, I'll go back to the searches there, hang on a second. I'll show some other searches here. So if we're looking, for example, I've done the headline search tells you how you're doing. So this search will tell you where you're up to. The other searches here tell you or suggest to you patients we should focus on. And so if we've got patients where we should be considering ACE inhibitors, if I choose one of these, and again, what you'll find actually is that this person is also diabetic again. Most of these patients who need ACE inhibitors and Flozin in the CKD group are, partly because of the criteria, but partly because diabetes is one of the biggest causes of CKD. Most of them are going to be diabetic, particularly the ones that we're going to be focused on this year. Again, it's highlighting that there are missing processes for the assurance concern, which again is foot check and smoking for us here. It's interesting. There's the 3 inbuilt QOF processes here, pointing out that blood pressure is not to target. I have the same thing. I prefer mine because I think the targets are more in keeping with the Welsh guidance on this one. But you'll see it's saying for this person, consider a statin. That's because they're diabetic and their blood pressure is over 130/80. Nice target for diabetes, 140/90. The assurance target, the assurance framework contract target for Wales, 140/80. We put both targets in for reference in the templates. If I double click on the consider ACE or consider statin or blood pressure not to target, they all open my pathway. There'll also be a little bubble on accessing health pathways, although I think that's going to be on everybody's desktop anyway. If I double click consider ACE for this patient, it'll come up with the template. Again, it's pointing out this person's not on statins. So it's like the consider statin here. When I hover over, it will tell me this person's Q risk is over 20%. They're diabetic with a Q risk over 10%. They're hypertensive with a Q risk over 10%, and their eGFR is under 60. I would admit that we have not been offering statins as readily as perhaps we should have done, and we're still finding patients a little reluctant to accept statin. I like the NICE patient decision aid. We've amended that, merged it into ours, and printed off with the patient's cholesterol and their Q risk, and you could either, we can text that to a patient so that it's not costing us, or print it out when they're there. Again, Q risk 2, NICE is very clear that you can use inbuilt Q risk 2 until inbuilt Q risk 3 tools are available. There is a couple of caveats on our templates. EMIS prefer that you use their own template, although we are still using the EMIS concepts in the background to drive this. But there is a disclaimer saying you are using it at your own clinical risk. If your Q risk score is under 10% and you have a patient with corticosteroid use, atypical antipsychotics, SLE, migraine, severe mental illness, or erectile dysfunction, and their Q risk 2 scores under 10%, we should probably be using the online Q risk 3. There is a prompt in this template that'll flag that if that happens. Realistically, the group we're targeting, it's actually quite rare to see Q risk 2 scores under 10%, and Q risk 3 scores will not reduce that. So I'm comfortable using Q risk 2. I think the reason we've not been Q risking people as well as we should is the disincentive of having to go to a separate site to do it. It'll point out this cholesterol is over 4. It's proposing a CKD code for this patient. And actually, the latest CKD code is G3A1, which is correct. The EGFR is 52. The ACR is under 3, so it's happy with that. It is saying the CKD moderate risk. It's got the link to the CKD template again. And again, it's got diabetes prompts. Q risk 2 over 10%, no statin. It'll flag that up for us with links to the patient statin decision aid that I mentioned it from NICE. Diabetes and HGV, so for season HGV medical, it gives you advice on diabetes driving. Diabetes template with the processes and links here, so if you, just for reference, if you want to see my Desmond or the NICE glucose lowering or the diabetes enhanced service and things, they're all there. Although it's a bit slow, there we go. We use the expert diabetes courses. That link will be to North Wales. It's pointing out there's no foot check. It's pointing out this person is also on a hypertension register. They've not had a review. It's been an active thing for years, but perhaps we should be coding these things better. It also says this person needs a smoking status. If this had been done and we had an up-to-date smoking status this year, it doesn't show it in the template. So if there's a process that's been done, it doesn't keep showing it. It'll disappear for a year. Same for alcohol. And this is what I mean about the blood pressure. The target for the assurance framework, TT04, is 140 over 80. NICE is 140 over 90, and there's links to NICE guidelines. And then it's pointing out the unis, lipids, weight, they're all up to date. I'll go back to some of the searches for just a few more examples of how these prompts work. So we might leave CKD for a moment, because I did want to talk about the overlap here between CKD and diabetes. Now, we have got our population for targeting here. If I go to diabetes, we've run a similar search. I mean, to be considered for finerenone, you have to be diabetic. So of course, the numbers are the same. They're there. When I look at CKD and I follow the various rules, I find there's about 40 patients who might benefit from considering a Flozin. If I look at diabetes, I find that number is 197. If I overlap diabetes and CKD, what I find is that number is 204. So there are only 7 people out of my 204 where we would be initiating Flozins on the basis of their CKD. The rest, it is very clearly a diabetic problem. Same for ACE. I mean, there's 129 patients on my practice where we should be considering ACE. Of those, 128 are diabetic. This is, I think we could have called this a diabetes optimization QI in all but name. I've got a few searches in the diabetes thing that looks at, who needs an ACR? I mean, this, out of my CKD and diabetic patients, the problem we have really is that we have not been chasing ACRs very hard in our CKD or suspected CKD group. And this is actually the numbers from those who should probably be coded as CKD, not the wider screening group. So if I go to that screening group I mentioned, this is CKD or likely CKD. 305 out of 409 have had it ever, but only 120 or so of my patients with CKD or likely CKD have had an ACR done. Only about 30% have had it done, which, when I look at the QI data and the national data, is probably better than average, but it's certainly the area that we're going to be pushing this year. The reason I want to show the diabetes and the diabetes overlap with CKD is, realistically, it's also a workload issue. There's researchers looking for how frequently we should be screening and monitoring according to the NICE guidance. There's reference to that in the QI paperwork. So we've got out of my 409 probably CKD patients in my population 7,000, 10 of them would need 3 monthly monitoring. And what I find is most of them have been in. Nearly 100 would need 6 monthly. So there is an issue here in that QOF was only once a year. And I guess there is a slight increase in the demand here when you think there's going to be an extra 30, an extra 100. and that is something that practices perhaps do need to reflect and consider and look for cluster or collaborative support. There's the searches for the cardiovascular disease project too. I'll do a separate video for that. And the searches for your AF, which are broadly in line with the assurance framework, looking to make sure that we're anticoagulating where we should. Again, they're married up to prompts for AF in the cardiorenal metabolics. If I open the patient from this list, you will still have the QOF indicators. Again, you'll see that they're diabetic. The AF anticoagulation advisor will point out to you at the bottom that there's no anticoagulation and stroke risk raised. Mine just says AF not anticoagulated. This person has a higher risk CKD concern, and when I hover, it's saying that the 4-variable kidney failure risk score is likely more than 5%, and will suggest that you go online and do that yourselves. It's useful to see this. This person is likely eligible for Flozin. Anyone diabetes over 50, frankly, will be, because I haven't seen many with a Q risk under 10%. But anyway, it's suggesting that if we do start a Flozin for this person, it's worth being aware that they are on glycoside and that we might want to reduce the glycoside by 50% here. That's for when you see patients with HbA1c's under 58 and eGFRs over 45 with glycoside or insulin. So it's quite nice to know there are these prompts there. The assurance concern here is pointing out that we're missing a foot check, blood pressure, ACR, smoking, and BMI for this patient. The current thing will only tell you blood pressure and foot check. It's not mentioned the other missing 3 processes there for this patient. And then again, it's the consider Flozin. This one because they're diabetic and heart failure. Diabetic with an ACR over 3 and an eGFR under 90. Consider an ACE because they're diabetic with an ACR over 3, and you can't see the hovered box for that. Blood pressure, the target is 140 over 90, but it's not been done for 2 years, and it's saying cardiovascular disease, raised HbA1c and eGFR under 90. Consider a statin because their eGFR is under 60, and these are the inbuilt EMIS prompts and pneumococcal and management plans. And if I open any of these prompts, again, it'll open that cardiorenal metabolic template, which will give you very similar things. So it's looking for not on a statin. It's the box Q risk because they're over 85. It's coming up as 0. They're already established cardiovascular disease. They're heart failure, and they're not on an ACE or an ARB. They're diabetes and heart failure. We should consider Flozin in that group, particularly if they're symptomatic. CHA2DS2-VASc scoring because of their AF. Their AF not anticoagulated, and there's no declined or not indicated codes. It's proposing a G4A2, eGFR 19, which makes them G4, and ACR 21, which makes them A2. So you can tick that if you're happy. It's suggesting caution with initiating Flozins. Again, pointing out CKD very high risk with links to nice guidance here. Links to the kidney failure risk equation, and it's, oh, hang on, there we go. So the kidney failure risk equation, when you open that, it's the link to the nice Excel document, and you need for that, it'll tell you that you need your age, gender, eGFR and ACR, and you put in the age, gender, well, age here was there we go. So if we put the age 0 for female, and if I went back to that, and eGFR was 19 and ACR is 21.5, you can see their 5-year risk of needing renal replacement is 11%. So my prompt suggesting higher than 5 is right here. I've validated that quite a lot, but it would need MHRA approval if we give it as a calculator for using. So it's a prompt at the moment. Again, the template for chronic kidney disease. And then the diabetic prompt, so raised ACR but no ACE, ACR over 3 but no Flozin, driving advice because of glycoside, the diabetes 8 processes, expert foot check, eye screening. This person's hypertension registered as well, needs their smoking, needs their alcohol, needs their weight. They're up to date for It's got the blood pressure target for diabetes here in Wales, and it's telling us that we're up to date for UNEs, lipids, and HbA1c here. So if I go back, I think that's most of the searches and most of an idea of how the searches work. I'll do a separate video for the cardiovascular disease. This is a modified version of my wider chronic disease template. My full template would show you a similar thing for all your chronic diseases in one place. I like my HCA template, which makes sure that if somebody comes in, that all the processes that patient needs are all in one place. I think we've created this one as a smaller free version to share for the QI this year. If anyone is interested in buying the fuller set, then please do get in touch.